very much, dear Professor Berger, chairpersons, ladies and gentlemen, dear colleagues. I'm very glad having been invited to this nice and interesting symposium here in Berlin and having the opportunity to speak about this behavioral outcome after the arterial switch operation. I will start my presentation with a citation by William Marler, who recently commented on the last outcome of adolescents after neonatal arterial switch operation in the Boston Circulatory Arrest Group. And he wrote, "Caring for the adolescent with surgically repaired detransposition of the great arteries can be one of the most satisfying experiences in congenital heart disease." And indeed, we have very low operative mortality, little cardiac medication, minimal exercise limitation, rare hospitalization, and, according to the definition, a good quality of life in childhood. So our focus of interest must be directed on long-term neurodevelopmental and behavioral outcome, and with respect to transition to adulthood, to academic achievement and psychosocial competence in order to have an enduring good quality of life later on. For more than 20 years now, we have experience with the systematic neurodevelopmental testing and studies in children with congenital heart disease and comparing them to normal and healthy children. And the so-called neurodevelopmental and psychosocial signature comprises a lot of different neurodevelopmental domains as neurologic status, gross and fine motor function, formal intelligence, speech and language, and brain imaging in the last years, as well as domains of psychosocial adjustment as academic achievement, executive functions, memory, visual spatial skills, attention, and social competence. So we have, by means of these evaluations of neurodevelopment, we have faced a new look at outcomes of infants with cardiac heart disease as elaborated by the Canadian longitudinal study from the last 10 years with little children with different cardiac defects. And they stated that after infant open heart surgery, children are at significantly elevated risk of developmental difficulties at school entry that enhances risk for learning challenges and decreased social participation in school age and adolescence. And indeed, we have to accept that functional disabilities as a comorbidity of complex cardiac heart disease. On this picture, we see the association between the severity, the degree of severity of congenital cardiac defect and the percentage of impairment of the development in school-age children. This was a work from Jill Vanofsky from Philadelphia. And in TGA patients, we have a moderate risk with about 50% of children suffering from mild or combined disabilities during childhood. But what are the risk factors for developmental impairment? Risks are multifactorial, and they are interacting. Patient-specific risks comprise genetics and parental intelligence, as well as socio-demographic status, the intrauterine development of the central nervous system, and perinatal cause, whereas procedure-specific risks comprise preoperative cause, perioperative parameters including the modalities of cardiopulmonary bypass, and postoperative cause. In the following, I will focus on the risk factor of intrauterine development of the central nervous system. Fetal Doppler studies and fetal and neonatal cerebral MRI studies of the last 5 to 10 years have shown us that the brain of full-term neonates with a cardiac defect has a structural similarity to that of immature preterm neonates. And there have been found interactions between an abnormal fetal circulation and the brain development. In the example of transposition, we have, in comparison to the normal, we have relative hypoxemia to the brain vessels compared to the normal. And indeed, alterations in cerebral structure and metabolism in conjunction with delayed one-year neurodevelopment have been found in these children. What about risk factors in preoperative course? The delay in structural brain development at birth carries an enhanced risk of periventricular leukomalacia after hypoxic ischemic lesions. In the MRI studies listed here, about 20% of neonates with transposition have those periventricular leukomalacia before Rushkind and before surgery, whereas more than 50% have these phenomena after the arterial switch operation. And the other phenomenon we talked about yesterday is the maybe increased risk of focal stroke by paradoxical embolic events after balloon atrial septostomy. But these facts are contradictory, we know. On this picture, I have summarized the possibilities of preoperative MRI brain lesions. Structural lesions, only structural lesions, may be extended interhemisphere clefts, reduced brain volume, open operculum insulae, periventricular leukomalacia, focal embolic event, or hemosiderin focus as relicts of hypoxemia. We know these perioperative parameters in the older era, deep hypothermic cardiac arrest of more than 40 to 60 minutes, especially in conjunction with superior vena cava oxygen saturation of less than 40%, has been associated, correlated with an adverse neurodevelopmental outcome in the later years. And as we talked about yesterday, reduced perioperative regional saturation index by near-infrared spectroscopy has been found correlated with adverse neurodevelopmental outcomes. In this work of Boston, we see this correlation here. And we have also a correlation between the incidence of these hemosiderin focuses in brain MRI correlated to reduced oxygen saturation. At the end of the first part of my presentation, I will give a synopsis between these risk factors and development after the publication of Jovanovsky. In fetal life, we may have abnormal cerebral resistance or oxygen content and genetic syndromes that may be at birth followed by an abnormal brain at birth with small head circumference, structural abnormalities, especially periventricular leukomalacia just in fetal life. Preoperative modifiers as low cerebral blood flow or oxygen continent or morbidities on the intensive care unit are additionally. The circumstances, modalities of surgery and cardiopulmonary bypass are added to this risk, and we have early modifiers from the ICU with protected hypoxemia, hypertension, alterations in cerebral blood flow, hyperthermia after the operation, and clinical seizures. And these risk factors may enhance early postoperative periventricular leukomalacia or enhanced clinical seizures. At age 1 year, we may have delayed motor and language skills and microcephaly. And in the later course, at midterm outcomes, the modifiers of reoperations, protected hypoxemia, socio-economic status, and so on, may lead to school-age problems as visual motor integration problems, inattention, hyperactivity, problems with behavior, handwriting, planning, and diverse executive functions. In the second part of my contribution, I will report on controlled studies of neurodevelopment after neonatal arterial switch operation dated from 1999 to 2011. I will focus on studies from Boston, Edmonton, San Francisco, St. Augustine, Milwaukee, Baltimore, Washington, and from our center in Aachen. I will start with a famous Boston circulatory arrest study primarily designed to compare the circumstances of circulatory arrest versus bypass modalities in arterial switch operation. Primarily 171 children, neonates, were enrolled, and the first results were published in 1995 by the group. At ages 1 and 2.5 years, they found reduced neurology, mental, as well as psychomotor developmental index compared to the normal population. The asterisks marked the domains which were found worse in the circulatory arrest group compared to the bypass group. They re-evaluated in a longitudinal study the patients at age 4 years. In this examination, neurology was found in the normal range, but all other domains were found significantly reduced versus normal. And the motor functions were less in the circulatory arrest group versus the bypass group. The next re-evaluation was done at age 8 years. In this examination, neurology was in the normal range and the intelligence, the formal intelligence as well. Whereas all motor functions, fine motor function, memory, academic knowledge, problem solving, visual motor function, attention, and speech and language were found significantly reduced versus normal. And again, the motor domains were worse in the circulatory arrest group. The next re-evaluation was at age 8 years with concern with respect to behavior. The child behavior checklist, parent and teacher related, was performed, and they found an increased rate of problems, total behavioral problems, externalizing as well as internalizing problems in the group compared to the normal, whereas their social and school competences were significantly reduced versus normal. Main risk factor in this domain were clinical seizures in the neonatal age, not bypass or arrest. And they did they performed family characteristics scores and found that parenting stress index, social readjustment, and family adaptability was striking. And the votes of the parents were associated to the parents' behavior ratings with respect to their children. The recent publication I faced in the beginning of my talk was done at age 16 years. There was an extended achievement battery performed, mathematics and reading, verbal and visual memory, executive functions with respect to letter, verbal, design fluency, and sorting were significantly reduced versus normal, and the behavior rating inventory global score was discrepant. It was rated normal by the children or adolescents themselves, but reduced by parents and teachers. This is a typical phenomenon. Visual spatial skills were found reduced, attention and social cognition. And this part of the examination is very alarming. Remedial academic or behavioral services were needed in 65%, 2/3 of these patients. Tutoring was needed in 37%, special education in 25%, occupational therapy 23%, and psychiatric medication were needed in 12%. The main risk factors of this was, again, seizures. The differences of arrest versus bypass declined with age. Also, MRI brain was done in this study, and in about 1/3 of the patients, anatomic abnormalities were found. Most of them were focal abnormalities, mineralization, defects of the white matter, hemosiderin focuses, atrophy and infarction were less. I will compare this to our Aachen studies. We performed one study in little children, mean age 3 to 4.6 years, where we found reduced neurology, but total developmental at that age was found in the normal range, whereas the control group was better. Then we started consecutive examination, longitudinal examination of 77 children. First time we examined them at mean age 5 years. And it was similar to Boston. We found all domains of development reduced versus normal except the formal intelligence. And in total, we found an impairment in one or more domains in 26% of the children. We re-evaluated them at mean age 10 years. Again, formal intelligence was normal. All other domains were impaired versus normal, but the total rate of impairment rose to 55% of the children. Recently, we evaluated the children once more in adolescent age. We found reduced neurology, most palsy children. Formal intelligence, again, in the normal range, but the executive score, one of the domains I mentioned before, was significantly reduced, where the formal and analytical thinking was in the normal. With respect to behavior, we had normal socio-emotional score in the little children. In the group, consecutive group, we had at age 10 years the same behavior problems and reduced competences as in Boston. At age 17 years, we made other examinations. We found that the patients were at less psychic stress than normal patients, but they had a very reduced orthography test, was a catastrophe. Special school attendance was higher, and 12% had no final school examination. We also performed MRI brain, and we found the same percentage of 1/3 of anatomic structural problems, most of them focal white matter injury, less reduced brain volume, or substance defects. Here an example of periventricular or subcortical leukomalacia 20 years after arterial switch operation. Other centers, for example, in Canada, examined in some younger publications children at 1.5 to 2 years. They also found mental and psychomotor developmental index reduced, whereas at age 5 years, intelligence and physiomotor function was normal in this publication, only language was reduced. The populations of San Francisco and St. Augustine at mean age 8 to 9 years found, again, normal formal intelligence, but reduced neurological, motor, language functions. Behavior in these groups showed normal behavioral data in little children, in the Canadian group and in Milwaukee, whereas the older data from the Baltimore-Washington infant study showed increased problems, parent-rated. And the child behavior checklist in San Francisco and St. Augustine showed also increased problems and reduced competences of their children in school age. What is now the new developmental and psychosocial signature after neonatal arterial switch operation? Whereas the majority of children have a normal development, of course, we have an increased and remarkable rate of dysfunction in school age of about 25 to 50% in the studies in one or more domains of development, and it persisted into adolescence up to 40%. The domains were neurology, motor function, language, attention, visual perception, cognitive flexibility, executive functions, academic achievement, and social competences, whereas, and this is not a contradiction as we know, normal quality of life was present. I conclude. The high rates of service use suggest important deficits potentially reducing school, occupational, and social success. Parental perceptions as guilt, stress, anxiety, or overprotectiveness may enhance developmental deficits. Procedure-related risk factors as cardiopulmonary bypass modalities have not provided the expected strong effects on developmental outcome. The differences between predominant deep hypothermic cardiac arrest and cardiopulmonary bypass strategies are low-grade. Patient-related factors as the congenital brain disease with cerebral maturation delay at birth, probably caused by the specific fetal circulation as well as genetic and social constellations, seem to be predominant. For the future, as strategies to mitigate procedure-related brain injury are limited, we should focus on prospective correlation between structural and functional brain imaging and development to achieve a current risk stratification, and focus on strategies to early recognize and rehabilitate developmental and behavioral deficits. We need assessment and intervention programs as for low birth weight children in Germany. And I will close my talk with our recommendations for all children after neonatal or infant cardiac surgery with cardiopulmonary bypass, as elaborated by the psychosocial working group of the German Association for Pediatric Cardiology. Besides the normal screening programs for children, we need extensive additional neuropsychological assessment at ages 2 years and 5 years in order to assess neurological, psychomotor, cognitive, speech and language, and psychosocial development at age 2 years, and cognitive, academic, speech and language, and motor development, as well as behavior and social competence at age 5 years. In case of abnormality or dysfunction, we should transfer the children to Centers for Social Pediatrics or Intervention and Advice, to Centers for Pediatric and Adolescent Psychiatry, or to other institutions in order to provide further diagnostics and therapy aiming at a normal quality of life into adulthood. Thank you very much.